You're listening to Medscape's In Discussion series on multiple myeloma, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Joseph Mikhael, Chief Medical Officer of the International Myeloma Foundation and Professor at TGen City of Hope Cancer Center. Relevant disclosures can be found with the episode show notes on medscape.com. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, my name is Dr. Joseph Mikhael, and welcome to the Medscape In Discussion Multiple Myeloma. I am a professor at the Translational Genomics Research Institute and the Chief Medical Officer of the International Myeloma Foundation. And today we're talking about a topic that is particularly dear to my heart for many reasons. Much of the work that I do is in the area of disparities in multiple myeloma. I myself, of being of African descent, this is a personal issue to me as well. But furthermore, I have the privilege today of interviewing and spending time with not only an eminent myeloma doctor in the field, but also someone who's become a very good friend of mine, Dr. Brandon Blue. Dr. Blue is an assistant member at Moffitt Cancer Center and focuses in on malignant hematology and multiple myeloma, especially in the areas of transplant and cellular therapy. So Brandon, it's always good to have you with me, and I really appreciate you joining me today.
Thank you so much. Happy to be here to discuss something that's near and dear to my heart, something that we do every day, and happy to kind of really share it with the masses.
Excellent. Well, you know, it's not a surprise that the whole area of disparities in medicine, or frankly in life, has really been a hot topic over the last several years. Things like the Black Lives Matter movement and many other things have, hopefully shone a light on a subject that has often been pushed into the background and not been fully appreciated. And that being said, it's something in the myeloma field that we have been talking about for many, many years because of some really important facts. And I just want to share a couple of those facts to kick off our discussion here today, Brandon, that I know are particularly important to the discussion and hopefully important to our audience as we think through this. One of the reasons why we've always focused on disparity in myeloma is because there is particularly profound disparity within the within the African-American community in particular. We see this in multiple areas, but in particular in multiple backgrounds. We see, for example, a disparity in the Hispanic community and in the uninsured, and actually paradoxically in the very young patients with myeloma, but in particular within the African-American community. And I reflect that disparity with a few key facts. Fact number one, myeloma is twice as common in this population. Fact number two, myeloma presents differently in this population in that the average age of diagnosis is 5 years younger. When we think of myeloma being a disease where the average age is about 70 or so for diagnosis, it's actually 5 years younger, about 65 within the African-American community. Point number three that we're going to spend a lot of time talking about today is we know, sadly and unequivocally, that access to therapies in African-Americans is significantly reduced to triplets, to transplants, to trials, the three big T's as I call them. And then now, Brandon, with you being an expert in CAR T, we're going to add a fourth T to that, even access to CAR T cell therapy. Fact number four, even before we get to access to therapies, we know that diagnosis is delayed within the African-American community more so than within the Caucasian community. This is a problem across all of myeloma, but particularly in this population. And then lastly, fact number five, which is maybe the one that gives us hope in all of this discussion, is that we've seen from multiple studies that when African-American patients are given equal access to therapies along with Caucasian patients, we know that their outcomes can be the same, if not actually better. So it's not that there is a more aggressive biology here. In fact, when given those equal access to therapies, we know that patients could do so much better. So with that as the quick background and the draw into us, these five big facts, Brandon, let's dive into, first of all, this issue of diagnosis and delayed diagnosis. And, from your estimation, I know obviously we're myeloma doctors, we're often not involved in that very first phase of diagnosis, meaning when people first present with anemia or back pain or renal insufficiency. But what is your take on why this is such a disparity within the African-American community?
Yeah, I think unfortunately myeloma falls into the realm of what they call a rare condition. So unfortunately, when anything is rare, it just doesn't get the limelight of some of the more common cancers. So everyone's heard of breast cancer, everyone's heard of lung cancer, prostate, even colon. But a lot of folks, they come to me even with the diagnosis of multiple myeloma and have never even heard of it and really don't understand really what it is. And so I think that's kind of a first problem is because if ladies or guys feel a lump in their breasts, they go seek medical attention. Unfortunately, you see blood in your stools, you go seek medical attention. But if you have back pain, you really don't seek medical attention a lot of times, especially if you talk about certain communities who have a less chance of going to see a primary care doctor in the first place. A lot of times for things that are like back pain, fatigue, those things we try to what we call tough it out. And unfortunately, it leads to delayed in diagnosis because, what should be treated with chemotherapy is unfortunately just treated with Tylenol or ibuprofen. And so what we need to do as a community is really educate people as far as early detection or even prevention of some of these things. As you know, multiple myeloma has a lot of precursor conditions such as smoldering or even what we call MGUS. So if we can catch one as a precancer, then that's even better than catching them once they become full blown. And so I think it really talks to us working not only from a big academic medical center, but really those folks in the community, as well as the primary care doctors, trying to figure out a way, how do we identify a population of people who are so at risk of developing this down the road that we catch them before the bones break, before the dialysis is needed, before they need blood transfusions. And that's one of the key things that I think we can talk about on ways to do that.
Yeah, no, that's fantastic, Brandon. And that you're hitting on such an important point, right? Is that, people don't walk into the office with a sign on their head that says, "Hey, I've got myeloma," right? There's no simple connection. Like when the ones you mentioned for breast cancer or colon cancer, that they tend to be a little bit more obvious. So diving deep into those classic signs and symptoms that are so vague, right? I mean, someone comes in with a little bit of anemia, or someone's got back pain, or someone's got a little bit of protein in their urine, or maybe they're getting some numbness and tingling, a little bit of neuropathy. All of those things, can speak of many other diagnoses, and especially within the African American community, it can speak to diabetes, right? This is one of the great mimics, as it were, where people, oh, that's just the diabetes, or that's just the way you are, without pursuing it further. And so I agree with you. I think a big part of this is recognizing that this could be myeloma, especially in that highest group. I often give talks entitled, "Could my patient have a plasma cell disorder? Could my patient have myeloma?" But then it's also the testing too, right? That just that first screening. The primary care docs aren't doing the marrows and all the fancy schmancy tests we do as hematologist oncologists, but if they could at least do the serum protein electrophoresis, the light chain measurements, those key CBC and biochemical profiles, that would really go a long way. And that's often, as you said, a challenge in a population that may not be going to primary care as much. So I think it's incumbent on us as hematologists and oncologists, as we build our networks with primary care docs, to help in that education of the greater incidence of myeloma. How do we do the right tests? When do we order, things like a serum protein electrophoresis and light chain testing? I think that's going to help overcome some of that disparity as we go forward.
Yeah, I think honestly, as primary care doctors are concerned, I think really there's two important tests that really they could potentially use as part of unofficial screening. A lot of times, as we know, the abnormal immunoglobulins build up when people have this condition. How we translate that into blood work is total protein. So if patients are coming, especially from a high-risk group of people, typically that total protein number gets higher and higher, especially as they develop more and more plasma cells. And so that's a very simple test that sometimes that, from a primary care doctor, you can kind of check or add on and say, hey, I have this African-American patient. I haven't checked the total protein. I don't really know what that would be. Check that. If it's high, then, honestly, I don't even necessarily need you to check the SPEPs and the light chains and those kind of things. If there's enough of a concern, because you say, hey, there's a high total protein, can you do the next steps? I'm okay with looking at that and kind of us clarifying, because as you know, that between non-secretory and secretory myeloma, sometimes it can be very nuanced, but at least if there's some type of a concern from a generalization, and that's a quick thing that you can do, as well as number two, albumin. All right. There's a lot of primary care doctors not checking albumin. And as we know, kidney disease is one of the major problems with this condition. As you see that albumin go from 4 to 3.5 to 3.0, maybe have myeloma be one of the reasons for that. Okay. And I think that, again, if you take a high risk population of folks where you're like, hey, this is, not what we call less likely, but actually most likely. Okay. And it'll never be at the top of the charts. It'll never be higher than high blood pressure. It'll never be higher than diabetes. But for sure, it should be, rounding out what we call the differential diagnosis, and as internists and as people who take care of people from all walks of life, a differential diagnosis really is what saves lives. Because you have, your thoughts on really what's the most common, but those other things what we used to call zebras really might not be zebras in certain populations. They really could be, in fact, exactly what's happening. And I think those two tests, a total protein and an albumin, could really kind of spark a little bit of change and say, there's really something happening there. Let me refer these guys over and let them do some more specialized testing.
That's extremely helpful. Thank you for that, Brandon. I think that's going to really help, obviously, for primary care docs maybe listening in, but even us as hematologists, oncologists, to give that guidance, because that is really what's going to save lives. We had a great podcast with Dr. Irene Gobriel, talking a bit about screening. And, when we screen even for breast cancer and colon cancer, we take into account a lot of the high risk features. Does someone have a family history? What is their age? And similarly, we're starting to move that direction here as well. All right, so let's dive into topic number 2. So we talked a bit about the diagnostic sphere. I'd like to talk about access. This is arguably the greatest area of disparity within the African-American community in myeloma. And as I sort of intimated from the start, Brandon, we talk about the 3 big T's, these 3 different approaches that have actually so improved the survival in myeloma. One of the facts I didn't share off the start was that, myeloma is one of the few cancers where we've seen such a massive improvement in survival in the last decade, which is wonderful. But sadly, we've not seen that within the African-American community to the same degree. So for all of this advance in survival in the Caucasian community, we've only seen about half of that advance within the African-American community. And we think a big part of that has to do with access to triplets, or the 3 drug combinations, transplant, stem cell transplant that still has a role, and clinical trials that we know can appreciably help people. And now I would argue we can add a 4th T to that, because we have recent data, including some of the work that you've done in looking at access to CAR T cell therapy. So I know that there's no simple answer to the access issue, Brandon, but I'd love to know your thoughts about this access problem and maybe even some of the things we can do to help overcome it.
Yeah, so I think really the thing that sets, again, multiple myeloma up differently is that it is a rare condition. So a lot of times with rare conditions, you sometimes need specialty care. You can't get a transplant, in rural America. You can't get a transplant in rural Florida, rural California. Typically, you need to go to big major centers. Okay. And so I would say the number one thing is that we have to work together as a team. There's no way that myeloma gets treated in silos, because if we do, unfortunately, we see that there is inefficient care. We have to really rely on our community oncologists to really take the patients in and then have to assess them and say, hey, I'm not sure if this person needs a transplant or not. Let me send them down the road. Okay. But then it becomes on the patient as well to say, all right, this doctor sent me for something that I'm not really sure about. I still need to go hear more about it and actually, what I call look underneath the hood, kick the tires, and really see, is this something that's right for me? Right now, we're in an era of what they call personalized medicine. And that's really for myeloma, one of the things that we try to do. But if you don't see myeloma often, then what you should do is really partner with some of these academic centers that specialize in myeloma. And so for me, I see myeloma every day. Each patient is a myeloma or amyloidosis patient. And so the expertise that comes along with that is a lot of familiarity of what to give, when to give, how to hold, how to dose reduce, some of those common things that are associated with this. And so I think that team approach is really the best thing that we can do to kind of be successful with treating this disease.
Yeah, no, I really appreciate your thoughts here. I mean, I think your notion of us not looking in silos is so important. I've often said, Brandon, I mean, when we look at the whole spectrum of how care is ultimately delivered in this country, from the regulatory authorities, industry, the healthcare systems, right down to the individual practitioner. Everybody's got to be a part of this solution. And even if we go a step further, which is maybe the most important step, which is embedding in the community itself. And so I think a huge part of this, and as you know, in the work that I do at the International Myeloma Foundation, which you have assisted us with and continue to work with us in the Empower project, where we are trying to empower patients and communities to change the course of myeloma. The course of myeloma, this disparity we're talking about today, is not acceptable, and we have to change that. And a lot of it is getting right down into the community. It's one thing to have, as you mentioned, these large academic institutions doing great initiatives, but what are we doing in the community, in the barber shops, in the community health centers, in rural areas where we want to break down the myths around cancer? So we want to rebuild much of that trust that has been broken. And what are your thoughts on that, Brandon? How do we reestablish that trust in a more general way, as well as specific individual practitioners? But how do we reach out deep into the community where, it's not like someone is trying to come in and rescue a community, but build an infrastructure within it to support them and the understanding of myeloma, so that when people do have some of these signs and symptoms we've talked about, they can go to a place and figure out, do I have myeloma or not? And if they know someone with myeloma, how they can best support them.
Yeah, I think trust is a big issue, regardless of where you talk about multiple myeloma, whether you're talking about heart attacks, whether you're talking about kidney disease, really being connected to the healthcare from a minority population is something that a lot of us are very leery about. All right. So the question that you asked is, how do we fix that? How do we make things better? I think number one is, we have to acknowledge, right? Say, hey, there is a problem in our healthcare system. A lot of times people try to make reference to things like Tuskegee and some of those things, which for sure, for historical purposes, are important. But we have to remember these things are still happening today. That's not something that was a one and done. That was something that, people go to the emergency room all the time, and they may even go and say, hey, I have back pain. But they say, hey, take these Tylenol and go home. And the patient's like, no, I've been to 4 ERs. This has been happening for a year. Like, something's wrong. And then they say, hey, go home, right? How many times do you hear that? That happens all the time. Or it might be situations where the patients are saying, hey, I'm noticing bubbles when I urinate, right? And people thinking that is something different than what it should be. So I think that recognizing and being like, hey, we understand that, hey, there's a problem. Right. And saying, hey, we're trying to make an effort. I think people want to be reasonable, especially people with cancer. Minorities are no different than anybody else. People are nervous and scared when they get cancer, and they want somebody to trust. They want to make sure that you have their best interest at heart. And so I think that if we just validate someone's concerns, I think that's a great first step in just saying, hey, I know what has happened. I know what is happening, but I'm on your side. We're on your side, and not only that, we are even partnering with the whole team, because we talked about the whole team approach. We have a team of people whose only job is to make sure that your cancer gets better. And then we talk about, I'll be, in charge of the treatment, making sure that gets away. Then I'll send you to, a place down the road to get a stem cell transplant. They'll kind of help you with that. If the disease even comes back, they even have a CAR T that can kind of get things up, to really kind of set the road to say, hey, this is our goal, especially as doctors, as researchers, as scientists. Our job is to help the people. Our job isn't to help the pharmaceutical companies or anyone else. Our job is to make people who are sick better. And actually, our job is to even try to prevent those people from being sick, right? And so I think we have to go in that with that type of mindset. Otherwise, we fail. And people can sense the realness about you, and we can't half do it and half step it. I think if we just tell people honestly up front, we are here to help you, then I think the trust is bound to happen.
Brandon, I could listen to you all day, man. I mean, I just, I just so appreciate your genuine nature and the thought around this. I think you're absolutely right. And actually, this is the perfect segue into our final little segment here to think a bit about how this affects us in the workplace. Are we recruiting and engaging people from the earliest of days to be interested in medicine, to be interested in myeloma, a disease that affects the African-American community more fully? And then at the other end of the spectrum, as hematologists, oncologists, what can we do more? I mean, I can imagine a white community oncologist listening to this conversation saying, well, what can I do? What do I do? But let's start on that first part of it. Tell us just briefly your story of what brought you into this field and how you wanted to give back to your community. It always touches me when I hear you say this.
Yeah, so for me, I am the first doctor in my family. Okay. I actually didn't know what I wanted to do, but my mom was like, hey, you're smart. So I said, all right, I'll do something in computers. I don't know. I'm good at math and science. So I thought computers would be the way to go. And then I used to get in trouble in school for talking. So I was like, all right, I talk too much to have a computer based job. I can't sit at a desk and just, number crunch, And so that's when, honestly, just through divine intervention, I lived across the street from a nursing home. And so I literally got a job across the street at this nursing home in the kitchen, and I was cleaning and I was making people's meals. But then the inquisitiveness in myself really was like, well, what is a renal diet? Like, I don't even know what this stuff is, and so I literally started to like go take trays to the people. And then I started to really like interact with them, hear their stories, start talking to the nurses, the doctors, everyone at this nursing home. And I was like, I can do this, And so for me, I said, all right, I'm interested in medicine. And then I said, all right, I want to see all walks of life. I don't want to see just kids or, just adults. I want to see everybody. I don't want to see just the rich. I don't want to see just the poor. I don't want to see just men and women. And so cancer was really something that, unfortunately, it hurts CEOs, it hurts janitors, it hurts the uninsured, it hurts the millionaires. And so I knew that was really, for me, a way to go. And so I was fortunate enough to come back to Tampa Bay, which is actually where I grew up. And right now I'm taking care of people who are past principals of mine, classmates of mine, people who literally go to church with my parents. You know what I mean? And so, this is my community. And so when I say, hey, this is a problem in the African community, I'm not talking about something that I heard of. This is something I know. This is people who I live with. These are people who literally their phone numbers were in my phone before I became a doctor. These are my community. These are my people. And so that's why I thought that was important. And so, how do we cultivate more Brandon Blues down the road is kind of what the question is. And I think really the thing is that I didn't get here by myself. There was a pipeline and process where people took me aside and said, hey, you're a budding, young, smart person who's motivated and interested. Let's kind of make sure that you hold on to these things and continue to be engaged. And I think that's really what we need is these programs. And there's so many programs that are out there, but I just think they just need to be kind of bolstered up a little bit to kind of follow through. It's okay to start a program, but for it to be a successful pipeline, you have to have something at the end of the road. And then to answer your second question is, what can we do? We need as many allies out there as possible. I would say you don't have to be a minority, oncologist like myself to be treating people in the African American community, because we see people from all walks of life. And unfortunately, we don't do as good of a job bringing minorities into our centers. And so majority of the patients I see are not African American. And so I would say that if you are in the community and you take care of, Hispanic patients, African American people who have been marginalized their whole lives, I think the one thing to do is to just have some empathy. I think just to know that this person's life may not have been similar to yours. This person's beliefs might not be similar to yours. The things that you grew up knowing your whole life, this person may have never even heard of. And so I think to have that as a mindset and say, this person is different. All right. And to just say, how can I still help them? I think that takes a special just notification and listening ears. That's all people want to do, is to have someone to listen to them and understand that they're for them. So that goes back to my original point. If we're empathetic, I think if we're good listeners, then I think we can be great doctors and continue to kind of move the needle forward. Because one thing about minority community that I can tell you is that we talk. Okay. So if you're a good doctor and you're taking care of that person, you may find, they're telling their church members, they're telling people at the barbershop, they're telling, the people in their family. So you might be taking care of a whole family of people, if you really have that kind of listening ear and say, hey, I'm here to help you. And people can recognize that.
Well, Brandon, you are a talker, but you're a great talker, man. And I could listen to you for hours. I mean, that you captured so many elements within that. I almost don't want to say anything else. You've described cultural competence when people talk about as some theoretical thing in a real way. And so we really appreciate it. I want to thank you for joining me today. This has just been an extraordinary conversation. And we've thought about so many different elements of health disparity in multiple myeloma, the delayed diagnosis, access to triplets, transplants, trials, CAR T-cell therapy, and indeed how this directly affects the workplace and how we need to build that pipeline that you described to encourage more people to come into this field, how we can deliver more culturally competent care in a way that is genuinely going to help people. We go back to why we went into medicine, right? We went into medicine to really help those who need the greatest help. So thank you so much again, Brandon, for joining me. This has been a marvelous conversation. We really appreciate all those who have listened to this and the other podcasts as we created this series, and we trust it'll be helpful to you as you care for your patients. Thank you very much.
Thank you for your time today.
Thanks for listening to Medscape's In Discussion Multiple Myeloma podcast series with our host, Dr. Joseph Mikhael. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com for show notes, links, and more information on multiple myeloma.